symmetrically. We're looking at maxillary incisor midline, and when we do this, it's very important that we split and we look at the glabella, which is the center point right in here. We don't want to use noses as a reference because noses are very bad references. I see dentists using the nose, and they try to line up that midline with the nose, but the problem is people have noses that aren't symmetrical. They'll tilt to one side or the other and they'll throw you. But if you always use this reference when you're doing your photographs and have your patient sit up and you go straight down here, you're going to have a better reference of midline, plus communicating with the technician. The next is a maxillary occlusal plane to the interpupillary line. So the maxillary incisor plane with the interpupillary line, in an ideal situation, we would like to see these lines parallel with each other. The problem is, many times they're not. You'll have one eye that is set higher than the other, and that's one of the challenges with the face bow, is because you get the face bow and it can do the same thing. You've got this, and you could, recapture that cant. And I'll show you what we use next to help with these kinds of things. The next thing is the maxillary occlusal plane and to the lower lip. So we want a smile line that follows the contour. Okay, there's a smile line. Here's the contour of the lower lip. Now you'll notice this patient kind of has this little drop down effect on their lip. Okay, so these are important things to identify and point out because, as you'll see in a later case, that can come into play. Then we've got the maxillary incisor facial inclination in relationship to the occlusal plane. Orthodontists are good at looking at this stuff, but sometimes we as general dentists don't look at it as much. But we want to look at that occlusal plane and the inclination of that central incisor. Is it got too much torque? Is it flared out? Is it retroclined? And this is why those lateral views, when we're setting up teeth, are important, that we've got the inclination proper. This patient's is pretty good, but she's got, see these lower incisors a little bit flared forward. Okay? Gingival levels is the next segment, amount of gingival display. So here you have an example of a patient that has not much gingival display. And then here you have an example of a patient that has quite a bit of gingival display, right? Why does this patient have so much gingival display and this one has very little? What are the factors that play into this by hands?
Growth and development, thumb sucker, oral habits when they're younger, affects facial growth, stuff like that.
Those can contribute. Any other?
What was the question? Sorry.
Why does this person have so much gingival display compared to this patient? They're both females about the same age.
Lip mobility.
Age.
So age, lip mobility,
Heredity.
Okay.
Passive eruption, maybe.
That could be it. One of the things I'm going to suggest is one of the biggest contributors to this right here is a facial profile. Okay. For example, and we'll get to that in a minute. Maxillary occlusal plane to the posterior teeth.
The other one has a deep anterior overbite, right?
What's that?
On the other one where she shows more, she looked like she had a fairly deep anterior overbite.
Probably did, so the teeth are over erupted.
Yeah.
Yeah. So here's some of the factors that can affect tooth position. Facial proportions. Okay, someone said, genetics. Does the patient have a convex or concave profile? Is it a flat profile? These have a direct factor on the tooth position. What about lip fullness and dynamics? Okay, this patient has pretty full lips, wouldn't you say? African American, full lips. This person has, they're not thin lips, but they're not nearly as full as that. So lip dynamics, someone mentioned lip mobility. And then of course the patient's desires, shape, etc. Some people want really big teeth, right? That's kind of a trend to have these big teeth now. Okay? So we really need to look at it from a facial perspective and a facial evaluation. So when we're looking at the lower third of the face, an ideal face would have somewhat of a proportion from glabella to the nasion to the chin point are going to be somewhat symmetrical. The lower third of the face here would be about 55%, this would be 45%. That would be considered like an ideal measurement. But some people fall far without that spectrum. Some people have very long faces, so they're going to have a much higher percentage down here. What makes a longer face? Well, this is me and that's my wife, okay? if you look at us, we have very different facial structures, right? My wife has more of a longer facial profile. Why does she? And look at her lip line. So when she smiles, she's got more gingival display. When I smile, good luck seeing any pink. So why is it that she shows so much pink, I don't show any, and how does our face shape play into that? Any thoughts or suggestions on it? If you don't know, then you'll know soon. Okay. All right. So let's keep this in mind. We've got long face, short face. When we talk about, if we just measure the length of the face, and then the next thing, I just happened to pick this off of Instagram, and this is a quick picture. Okay. These are some celebrities. You got Angelina Jolie. That's Rihanna. Who's these other? That's anyone recognize her?
Emma Watson.
My Granger.
Huh?
Emma Watson. Yep.
So
Yeah.
basically, they looked at this gonial angle, okay? And on a male, this angle on average, ideal would be considered 130 degrees, but on these women, you'll see a variation from 123 to 127, 124. So when we talk about this angle, I also call it the mandibular plane angle, okay? Right here, that's what they're measuring, that right there. See how hers is a little more flat than this one? So a patient like my wife, if I showed you a side view of her compared to a side view of mine, what you're going to notice is someone that has a longer face shape, their gonial angle is going to be much steeper. They're going to have a steeper mandibular plane angle from here to here. They're also going to have the ramus height is going to be much shorter. So the ramus height from the condyle to the border of the ramus right here, you're going to find that they're much shorter. Therefore, they have a steeper mandibular plane angle. It's almost intuitively seems backwards. By contrast, you get a guy like me, and if you look at my profile, I have a longer ramus. Okay, my ramus height is going to be longer. Therefore, I'm going to have more of a square, what we call shorter facial structure, or some people will call it brachycephalic. There's normal, there's brachy, and then there's that dolichocephalic. Dolichocephalic will typically have that really steep mandibular plane angle. So these mandibular plane angle patients like that have steep mandibular plane angles. They have a tendency to have their vertical growers. So they have vertical maxillary excess. They often have a lot of gingival tooth display. They're also one of the most challenging aesthetic patients to treat, right? Because they show everything. They show the margin. They show, my wife has the kind of teeth, when you look at, she's got a pretty smile, but the shape of her teeth, I told her, I said, listen, if you ever had tooth trauma to your front tooth, you're a nightmare from hell to restore. You're the worst one that I wouldn't ever want to have to restore, because the teeth, the shape of the teeth, the fact that they show anyone, it's difficult. So protect your teeth, don't get hit in the face. You could knock out my tooth and you could put a horse tooth in there and you might not notice it as much, right? It's just the difference in face and lips. The other thing to consider is, has anyone ever had the experience of placing an implant somewhere in the anterior segment of the patient, and then seeing the patient a couple of years later and noticing that the size of the ledge position changed? Let's say you have an implant here and a natural tooth here, and then a few years later they lined up when you seated it, and then all of a sudden it's changed a few years later. Have you seen it? Have you seen it? Well, you do enough implants like I have, you're going to see it eventually. Why does that happen? We used to think that, well, why wouldn't you put an implant, Jared, in a male patient that's 16 years old in a front tooth? Why would it not be a good idea?
He's still growing.
Yeah. So if he's still growing and you put that implant in there, what's going to happen?
Stuff will grow around it.
Yeah. So 16-year-old male,
gonna
implant
grow
goes in the central, that implant stays put, everything else grows like this, right? You've got a massive gingival discrepancy that you can't really correct. It's a horrific problem to deal with. So the growth and development people will typically say, well, females are done growing facially earlier than males, maybe by 20 they're done, but males can have this latent growth spurt. I've seen that happen in 60-something-year-old women. I had a lady come in my office, she had an implant on a front tooth. I didn't do it, it was done years ago, and she had a natural tooth. They were about 2.5 millimeters difference. I said, I'm assuming when your dentist put this on that your edges were the same. She goes, yeah, they used to be the same. There's no evidence of any kind of wear or attrition. What happened? Well, she had growth of her premaxilla. So all the neighboring teeth went down, an implant stayed there, and she's got massive gingival discrepancy lines. So the take-home message is, I delay implant placement on adolescent patients as long as I can. Like I want that period over with, because that's a really, really difficult challenge. But why is it one patient gets it and one doesn't? How do you predict who's at higher risk? The vertical grower is the one that will bite you. If they have steep mandibular plane angle and they have that high line, avoid it like the plague, because they're going to have that implant that's going to do this on you.
Those are hard ortho cases too.
What?
Those are hard ortho cases
Yeah.
too.
Yeah. So there's that dolichocephalic. This is that long face. Again, look at her mandibular plane angle and look at that short ramus height. There's also a famous orthodontist named Dr. Ricketts. He developed this thing called the E-plane, and he basically took a line from the nose down to this chin, and he said, you know, ideally that upper lip should be 4 millimeters from this point and 2 millimeters from here. Well, you can see she's pretty much on that, right? Which would indicate that she's probably, you know, her Ricketts is not, certainly Ricketts plane is not ideal. This is, again, measuring glabella. This is that same